You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal, Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I am Dr. Ann Cross, and welcome to Medscape's In Discussion series on multiple sclerosis. Although many MS patients are diagnosed when in their 20s and 30s, the entire population of people with MS in the United States is getting older due to many factors, including longer MS life expectancy, better disease-modifying therapies, and just better healthcare in general. A health claims data analysis of 45% of the U.S. MS population done by Mitch Wallen and published a couple of years ago showed a shift toward older adult MS patients. And in fact, the peak prevalence observed in those was aged 55 to 64. However, in most of the clinical trials leading to the approvals of various MS disease-modifying therapies, the upper age cutoff was 55, and the median age of people in those trials was typically in their 30s. So, as a result of the near normal life expectancy in MS patients, the number of adult patients who are older is expected to continue to increase. And this brings up the idea of discontinuing disease-modifying therapies in older MS patients, and in particular, those who have been stable without MS relapses for many years. So currently, there have been 3 trials underway to try to answer whether it is safe to discontinue disease-modifying therapies. And we're fortunate today to have as our guest Dr. John Corboy, who actually started the first one of those, and it has just recently completed, and he'll talk to us about that. And Dr. Corboy is a professor of neurology and executive vice chair of neurology at the University of Colorado School of Medicine and medical director of the Rocky Mountain MS Center. Welcome, Dr. Corboy.
Thank you very much for having me, Ann. I'm very happy to be here.
So I'd like to start out by just learning a little bit about you. What led you into medicine and neurology and specifically multiple sclerosis?
You know, like many people, I had a significant interest in biology and chemistry growing up. But most importantly, my mother always wanted me to be a doctor. So even though I was in a graduate program at UCLA in anthropology, actually physical anthropology, my interests then were actually on evolution of brain and behavior. And when I realized that maybe medicine was a better choice for me, it was a natural fit for me to go into neurology. And I had the good fortune to have as my attending physician, my very first rotation in neurology was Arthur Asbury, who's one of the godfathers of American neurology and literally wrote the book on clinical neurology, one of them. And so some of it was just happenstance. I happened to run into tremendous neurology people where I trained at the University of Pennsylvania. And after that, I got interested in multiple sclerosis, again, in part because of my interest actually in virology. And for many individuals, especially in the last 30 to 40 years who went into MS work clinically, many of them were actually virologists because there was a strong concern, or at least hints, that MS may be in part related to various infections. And that's playing out over time with new data on Epstein-Barr virus infection playing a very significant role, maybe not a causative role, but certainly something that's necessary, if not sufficient, to be associated with development of MS. So like many people, I got trained in that mode in my fellowship at Johns Hopkins, and it was natural to continue doing that at the onset of my career. And then I started the University of Colorado MS Center in 1997, and after that, it's all been downhill.
You mean uphill or I don't know. Anyway,
or
in a good
uphill.
direction. In a good direction.
Yeah, that's right.
So you recently completed this multi-center trial looking at disease-modifying therapy discontinuation in older adults with MS. And I guess I'd like to know why you started that, why you proposed this trial.
Well, as you mentioned, Ann, a big part of that is that there was a fairly significant disconnect between what we saw in terms of an aging population. And I've been in the same location as you have for many years now, and many of my patients have gotten older, and we've seen how things have developed with their MS during the treatment era. But more importantly as well, we see that the natural history of MS has been pretty well defined, and relapses and new MRI scan lesions diminish with age. In addition, there's a significant amount of observational data that the people who benefit the greatest from the presently available disease-modifying therapies are younger patients and the ones who don't have recent MRI activity or recent relapse activity. And in addition, unfortunately, for those patients who, as they age, develop progressive MS, it looks like the therapies that are presently available are just not as useful as we would like them and need them to be. So this confluence of the natural history, understanding the aging population, the fact that large numbers of these studies that have been completed for approval of the disease-modifying therapies have been completed in people under the age of 55, all led to the question as to whether or not it made sense to continue to use disease-modifying therapies in those older than 55, because we just don't have data showing efficacy, and there's natural history data suggesting that it may not be necessary.
So what were the criteria to enroll in your study, which I believe was called DISCO-MS or DISCOMS?
So the main criteria were that you had to be 55 and older with no relapse of new disease activity with your MS for at least the last 5 years, no new MRI lesion for at least the last 3 years, while continuously using one of the standard FDA-approved disease-modifying therapies in MS, with a couple of exclusions for long-acting drugs or drugs that had very little usage in the United States, such as alemtuzumab. And those were the primary criteria. And of the people who actually ended up in the study, the mean age was actually 63. 83% were women. Almost 90%, 89% were white. The majority, about 83%, also had relapsing remitting MS. That is, we would accept people with progressive MS or relapsing MS, but most had relapsing MS. And they could be on any of a number of different disease-modifying therapies, but about 73 or so percent were on the older injectable drugs, one of the interferons or glutathione acetate. A smaller number then were on dimethyl fumarate or one of the newer therapies, such as the monoclonals and Gilenya. So it was a wide range of different therapies, about 8 different classes of medications, but the majority, 73%, were on the older injectable medicines, and the majority were white women. So even more so than in some of the routine studies that we've seen with MS.
Was it difficult to convince other neurologists to take part in this study, or patients for that matter to take part?
I think it was actually both. The reality is that when we tried to include sites throughout the United States so we could get the widest, most diverse population possible, we asked essentially all the usual suspects, if you will, for people who have contributed to a variety of different studies. People who are very good at doing these studies. And 3 or 4 of well-known large centers essentially said they didn't think they could participate, especially in part because of 2 things. 1, their populations had really never brought it up as an issue. Or 2, that some of the investigators, especially some of the younger investigators, interestingly enough, were uncomfortable with the idea of taking people off medication. And I think it is notable that the younger investigators seem to be more concerned because they may have been sort of raised in an environment where people always got treated. And they didn't have an opportunity to see a lot of older patients and people who had not been treated ever and see how they did over time, so that their view of the world was a little bit different. But importantly for the patients, we did a side study. We did an interrogation of NARCOMS, North American Research Committee on MS, which is 30,000+ people who have MS and who regularly contribute to a variety of different surveys. And we surveyed 1,000 people, got almost 400 responses, and asked them just a simple question. And these are people who actually look very much like the people in our study. That is over the age of 55, many using older injectable drugs, all on drugs, and ask them the question, would you be willing to consider a trial off of disease-modifying therapies if you're presently on them? And it was remarkable because 66% said no. About 20% were neutral, could go either way, but only about 12% or so said that yes, they would clearly be willing to consider a trial off of disease-modifying therapies. So we knew as we were beginning the study that there was a significant concern, especially I think amongst people who are stable, that if it ain't broke, why would I try and fix this? If you're stable, tolerating your medicine, these are people who have been on medications for a long period of time, the older injectable medicines for sure, for 15 or 20 years. Why would you stop if you're stable? And that really was a hindrance. And we can see that in the sense that we actually screened over 5,500 people to obtain 259 that got randomized, 128 to stay on their drug, and 131 who were randomized to go off of their drug. So it took quite a few people, and many of them, of course, just didn't fulfill the inclusion criteria, but many who did just elected to not participate. So it was a barrier.
Yes, I can attest to that because, as you know, I was one of the sites and I had quite a lot of difficulty convincing people to participate. And some people were worried that if they had a problem, they wouldn't be able to get back on their drug, because insurance might say you don't need it any longer. So I guess, you did the first study and it's completed. Are you able to share any of the initial results from this study, DISCOMS?
Sure, I'd be happy to share the results. As I mentioned, we randomized 259 people almost evenly between the two groups. I mentioned the individuals who went into the study, and also a couple of things I didn't mention that are of note. The average time since disease onset was about 22 years. Interestingly, the average time since last documented relapse was almost 14 years. So these people were quite stable on their disease-modifying therapies. And in addition, they had sort of a moderate level of disability. We have a 10-point scale called the EDSS scale. And on that 10-point scale, the average is a little bit over 3, which suggests that there was a moderate amount of disability, but not necessarily a significant gait impairment as yet. That people just sort of entering into a phase of potential gait impairment on average. I mentioned the average age was 63. We had people well up into their 70s. And so from an age point of view, it was a pretty broad group and mostly relapsing patients. The average amount of follow-up time was about 22 and a half months, a little bit longer in those who were on drug compared to those who went off drug, but not statistically different. So about 22 months of follow-up. And we looked at a variety of different outcomes. And the primary outcome was whether or not someone had a new documented relapse or if they had a new brain MRI scan lesion. And patients were monitored every 6 months, and they had a baseline MRI scan that was done prior to their entry and had to be proven to not have new activity on it. Then a scan at 6 months, 12 months, and 24 months. And although we asked people to have contrast given so we could see if there was so-called enhancement, leakage of the dye into the brain after the injection of contrast material, we knew that many people would not be doing that because it has become the standard in the United States to use much less contrast over the course of the last 5 or 6 years. So we did not include the enhancing lesions as a primary outcome measure, but we did look at that at least a little bit. So the primary outcome measure was any new relapse, any new scan change. And then we also looked secondarily at disability progression on that 10-point scale, the EDSS. A confirmed disability progression at 6 months. That is, if you measure someone and they had a change and it was confirmed as persistent 6 months later. And then we also looked at a variety of different quality of life measures, symptom measures, and other measures such as that. And interestingly, something that's not often asked, and that was, what was your satisfaction with your treatment at the various times? We asked that every 6 months, including at baseline and at the end. And that was to get an idea of people's happiness with how they were doing with this and the satisfaction they would have if they considered a trial off medication. And so patients were seen every 6 months. We measured these different outcomes. And we interestingly did something called a non-inferiority approach. That is, we tried to look at not whether or not one was better than the other condition, that is either on or off drug, but since there was a standard of care, which is staying on the medication, was it inferior or not inferior to go off of the medication? And this statistically is a slightly different question. And you ask ahead of time, not after the fact, what is the margin of error that you would accept? That is, if we anticipated, and we did, about a 2% number of people that would have a new event, a relapse or a scan change, how close do we have to be to that 2% to say, this is not inferior? And we predetermined that a margin of up to 8% would be considered reasonable, that if it was 2% in the continue group, we would accept up to 10% within the confidence limits, that is 95% confidence limits, that is the error margin, if you will, and that would be considered non-inferior. So we looked at the primary outcome measure, and it turns out that of the 128 people that continued drugs, 6 of those 128 had a new event, 1 had a relapse, and 5 had 1 or more new scan changes. Amongst the discontinue group, that number was 16 of 131, or 12.21%. So in terms of the margin was within 8%. But if you look at the confidence limits, The confidence limits, the error margin around that was actually outside of that. So what we can say is that we could not show that it was inferior, but we further could not demonstrate that it was non-inferior. And so I think the main conclusion is that it could be inferior. When we looked at only relapses, there was one relapse in the continue group, and there were a few more amongst the group that was in the discontinue group, that is 3. That was not statistically different. The major difference that occurred between the groups was the number of people with 1 or 2 new brain lesions on their scans. And of the 22 events, 6 in the continue group and 16 in the discontinue group, 15 of those 22 were people that simply had 1 or 2 new dots on their brain MRI scan over the 22 months of the study. And so the clinical significance of 1 or 2 new lesions, not exactly clear, but that was where the major difference was. When we also looked at enhancing lesions, again, not part of the primary outcome measure because only at a maximum 83% of people actually got the contrast injection. And by the 24th month, actually only about 60% did. 6 of those people who got scanned had new enhancing lesions on their scan. Interestingly, all of those occurred in those who went off of their disease-modifying therapy. And also interestingly, 2 of those individuals did not have a little white dot on their brain scan on the FLAIR images, that is, had an enhancing lesion independent of that. So a small number of people had enhancing lesions, but they were all in the discontinued group. I would conclude from this, for the primary outcome measure, that clinically there was not much difference, but there's probably an increased risk of having new disease activity on the MRI scan. And then the question is that significant enough that someone would want to stop a consideration of going off their medication? Or is that modest enough that someone would say, I can accept that risk in this context? When we looked at the secondary outcome measures, progression of disability was 11% in the continue group and 12% in the discontinue group. And there was no statistically significant difference. In addition, the vast majority of people who had progressive disability actually were not seen in those with progressive MS when they entered this study. 83% of the people with progression actually had relapsing MS. And the vast majority of them, 28 of the 30 people that had progression of disability, actually had it completely independently of the primary outcome measure. That is, they had no relapse and they had no new scan change. And we've now learned in the last several years that this progression independent of relapse activity is very prominent, not just in older individuals, but also in younger individuals. The vast majority of progression in the younger patients when they have relapsing MS is independent of relapse activity, and that persists throughout the lifetime. And that's one of the interesting little side things we saw in this study. And so other things we looked at in terms of quality of life and symptom measures and whatnot were really no different between the 2 groups. And as I mentioned, we did look at a satisfaction score, and the satisfaction score did show that at baseline, about 75% or so of individuals in both groups were satisfied with what they were doing. They were perfectly happy on their medication. At the end of the study, that number was almost identical in the continue group. It was actually 77.8%. But in the people who went off of their medication, actually, the satisfaction went up. It was over 90%, so that there was no unhappiness about going off medication. In fact, if anything, those who went off medication felt well, and there was no difference in terms of adverse events, serious adverse events, or other things between the 2 groups. So from that point of view, I think people did just fine, and the main difference that we really saw was likely a small increased risk of new disease activity as manifested by scan changes, but only as scan changes, at least during the time frame of the study.
Well, that's very interesting. Have you done yet any subset data analysis, like the age 65 to 75 versus 55 to 65 or race?
Yes, there were so few new relapses that it's really not meaningful to do any kind of subgroup analysis. And similarly, even with the counting of the MRI scan lesions that were new, nothing really shook out. We actually did look at that. We also looked importantly at the different medications, and the different medications, because of the small numbers with those who are using the oral medications or also the monoclonal antibody IV drugs, we didn't really see much. But if you look just amongst those who were on the different medications that were older injectable medicines, we really didn't see any subgroup analyses that were helpful. So I think the big answer from a subgroup analysis point of view, didn't really learn that much. And to probably have done this, given the relatively small number of outcomes that we could measure, we probably would have needed quite a few more people.
Mm-hmm. And I don't think these other 2 studies that are still ongoing have any more patients than yours did, do they?
No, they don't. And in fact, if anything, they're a little bit smaller. One of the studies, so Dr. Cross is alluding to a study in France looking at progressive MS patients, 50 plus in age. They will have 250 participants. Otherwise, a very similar kind of study to ours, but they're looking primarily at progression of disability as the main outcome. And then there's a smaller study, 130 patients in the Netherlands with ABAS stribus. Interestingly, they're looking at anybody 18 and older who's at least been stable for 5 years with no significant scan change for 5 years as well. So you could be diagnosed at 13, go on medication, be stable at 18, and go off medication in that study. It'll be very interesting to see. That is a very broad group. We would expect to see significantly more new disease activity. And one of the concerns, of course, especially in younger patients, is if you go off of one of the S1P modulators or maybe natalizumab, there's a significant concern for rebound of disease activity. And multiple studies have now shown, observational studies, that the number one indicator, at least for fingolimod, Gilenya, for disease recurrence or rebound is actually age. And so it'll be interesting to see what happens with that. We, again, did not have large enough numbers that we could show that, but it is true that we did have in our group, just looking at the primary outcome measure, of the fingolimod patients, we only had 18 patients. None of the 12 who stayed on drug had a new problem. One of the 6 who discontinued medication actually did have a new MRI scan change. With natalizumab, it was only 4 people in the study, but one of the 3 people who had discontinued drug did in fact have new MRI activity. So very small numbers, but that's the biggest concern because those are the drugs that really we have potential for a problem.
Mm-hmm. So I'm interested in what are your thoughts on de-escalation if you have an older person who's on a stronger, more aggressive, but riskier medication?
Yeah, I completely agree. There's really 3 options in this context. 1, you could just continue doing what you're doing. 2, you can discontinue all disease-modifying therapies. Or 3, you could switch to an alternative because the risks of some of these medications clearly go up as you age, especially for risks of infection, especially things like shingles, which are extremely common in general as you age. But many of the more significant medications, such as the monoclonals, have that as a risk as well, independent of age. So there could be a confluence of infection risk, especially or perhaps cancer risk, that as someone ages, you'd like to try to avoid. We have published a paper looking at the impact of different medications when you use them in younger patients compared to older patients. And we showed in this paper that was published last year that there's a wide disparity when you look at people who are younger and they're using either, in this case, it was the oral medications versus natalizumab, a wide difference in terms of outcome. As people are older when they start these medications, about age 53 or so, there's really almost no difference in benefit when you look at those. So the benefit probably diminishes as you age, yet the risk may go up. So we are starting shortly a study de-escalating from CD20 agents such as rituximab and ocrelizumab and ofatumumab to fumarates. And the logic would be just that, to lower the risk, because as we know with CD20 agents, risk of infection absolutely goes up over time with disease duration using the drug for a longer period of time because your antibody levels, your immunoglobulin levels go down. And that is a risk for infection. And the biggest risk for infection in the study that we published a couple of years ago was actually disability. If you were in a wheelchair, you have about 8.5-fold increased risk using rituximab to have a serious infection, such as, requiring IV antibiotics, compared to someone who is not in a wheelchair. And of course, more people who are older are more likely to be in a wheelchair. So that kind of risk is very palpable as people age.
So getting back to the DISCO-MS study that you did, what would you say are the limitations of that study?
And every study has limitations, and ours certainly did. You can only say this population, this is what we saw. And, this was a population of people 63 on average, last relapse on average 14 years ago, and most using the older injectable drugs. So as we were discussing, we don't have a great idea about specific medications. Or can we really say that maybe if you were able to push the age up to an average age of 65, or could you do a subgroup analysis and look at everybody below the age of, say, 63 and everybody above the age 63? Is there a difference there? We really didn't have enough people that we could actually do that. In addition, most of the people in the study were white women. They're all in the U.S., so we can't really say anything beyond that. And those were the main limitations: subgroup analysis, the population you look at itself, and just those things.
Thank you so much, Dr. Corboy, for spending your time with us today. We have talked to Dr. John Corboy about discontinuing medications in older patients with MS. Dr. Corboy conceived of and led the first ever study of discontinuation of medications in people with MS. So thank you so much for joining us, Dr. Corboy. I've certainly found this extremely informative, and I hope that our audience has as well. And so hope to see you again soon and see more data coming out from DISCO MS.
Thank you very much, Dr. Cross, and thanks for participating in the study as well.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple sclerosis.